Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. What I'm going to be sharing with you today is a nice and typical example of optic nerve invasion in a case of retinoblastoma. So this is a case of a 2-year-old male patient who was diagnosed with right eye retinoblastoma. And this is a low power or actually scanning magnification of the inoculated globe, the PO section, the pupillary-optic nerve section, which is the single most important section in order to render the proper diagnosis as well as to assess the high-risk features that are characteristic of retinoblastoma. So we're going actually to zoom in here first of all, and this is the tumor, this is the retinoblastoma, and as you can see here, there is formation of rosettes, the homobright rosettes, in which fibrillary structures are seen within the space in between the aligned nuclei of the retinoblastoma. There are areas of necrosis and apoptosis here, and there is a kind of moderate degree of anaplasia in the tumor cell nuclei. Now, zooming here into this focus where we have actually, this is part of the detached retina, and we have two separate growths that are identified within the retina itself. This is a higher power magnification of one of those foci, and these are the different 10 layers of the retina. And then we have here the third area that we should always examine whenever we are in reporting a retinoblastoma tumor case, and this is where we have our anterior chamber. This is the cornea, this is the limbus where the cornea meets with the sclera, and this is the ciliary body, and this is the iris. These are the three areas that we should always focus on whenever we report a case of retinoblastoma, because assessment of involvement of any of these structures would mean a higher risk for the patient and a higher stage for the patient. Now, zooming in into the only high risk feature that was present in this case, which is optic nerve invasion. And as you can see here on a medium power magnification, this is the tumor, this is the head of the optic nerve, this is here and here the sclera, and then we can see that the tumor has infiltrated or invaded the optic nerve beyond the limits of the sclera. So this is post-laminar invasion of the optic nerve, and the optic nerve enters, the optic fibers actually enters through the sclera, through the lamina cribrosa, and involvement of the optic nerve, especially post-lamina cribrosa. If we draw here an imaginary line that would connect the inner layer of the sclera, this is where, if we see a tumor beyond this imaginary line, this is what we consider as post-lamina cribrosa invasion of the optic nerve. And this is, again, just to highlight again, this is the sclera, this is the optic nerve, and this is actually the boundary of the lamina cribrosa, and any tumor beyond this boundary is considered to be post-lamina cribrosa invasion, a very important high-risk feature that should always be looked for and assessed whenever we assess a case of retinoblastoma. This is why we have to keep on examining multiple deeper levels, sometimes 5, 10, 15, 20, whatever it takes, until we have a full face features or section of the tumor, as well as the optic nerve clearly dissecting or infiltrating or bypassing the sclera. And this is again on high power magnification, where we have here the basophilic structures. This is a smudging of the tumor cell nuclei, and this is the intact tumor cells infiltrating the optic nerve. Again, on higher power magnification, this is is the smudged area of the chromatin, and these are the intact optic or the intact retinoblastoma cells. Why is it important to look specifically into the level of invasion of the optic nerve? Because actually the optic nerve is in direct continuity with the central nervous system. This is the sclera, and this is the optic nerve, and this is actually the dura mater, and this is again here, for example, the meninges. These are the meningothelial cells of the meninges, which means that infiltration of the optic nerve, especially post lamina cribrosa, would automatically mean there is a high risk for involvement of the central nervous system. This is why it's extremely important to look meticulously for any evidence of invasion of the optic nerve, and then decide on the level of infiltration of the optic nerve, because the optic nerve is in direct continuity with the central nervous system, and this is considered a very high risk feature. So the final diagnosis in this case is right eye retinoblastoma, stage PT3B, since there is involvement of the optic nerve beyond the lamina cribrosa. Remember that invasion of the optic nerve is one of the high risk features that should be assessed meticulously whenever we report a case of retinoblastoma. The other features are the choroidal invasion, as well as the anterior globe structures invasion, including the ciliary body, for example, or the anterior chamber. Remember that the pupillary-optic nerve, or PO section, is the single most important section whenever we assess retinoblastoma, and we have to go sometimes so many deeper levels until we have a full face of the whole globe, including the optic nerve, as well as in order to be able to assess any infiltration of the optic nerve, whether this was before at the level of the lamina cribrosa or post lamina cribrosa. Of course, we have always to mention whether the cut end or the cut margin of the optic nerve is involved or not, especially whenever we have invasion of the optic nerve beyond the lamina cribrosa. I hope you find this tip useful in your daily practice. Thank you.